Positioning Lesson 12 is Digestive System Contrast Studies, the most advanced GI positioning lesson. 16 minutes covering barium versus water-soluble contrast, the upper GI series, small bowel series, contrast enema, esophagram, swallowing studies, surgical cholangiography, and common GI pathology. The contrast decision and perforation precaution are directly tested on the ARRT. 2 positive contrast agents and 1 negative contrast agent. Know when to use each. Barium sulfate, the standard GI contrast. High density, excellent mucosal coating. Barium sulfate is chemically inert. The gut does not absorb it. It comes in different concentrations for different procedures. The critical contraindication: never use barium if perforation is suspected. Barium leaking into the peritoneal cavity causes a severe, often fatal, chemical peritonitis. Also never use if aspiration is a significant risk. Water-soluble iodinated contrast. The substitute when perforation is suspected. If it extravasates into the peritoneum, it is rapidly absorbed without causing the catastrophic inflammatory reaction barium produces. Lower density than barium, less mucosal detail. Also used preoperatively when barium is contraindicated. Negative contrast, air or carbon dioxide. Used in double contrast studies to distend the bowel lumen. The patient ingests gas-forming tablets or air is insufflated directly. Combined with a thin barium coating on the mucosa, double contrast technique. This provides high-resolution mucosal detail superior to single contrast alone. Best technique for detecting small polyps and early mucosal lesions. Upper GI procedure. Patient fasting 8 hours. Empty stomach required for full visualization. Barium suspension is given to drink during fluoroscopy. Fluoroscopic spot images are taken throughout. The patient is turned through multiple positions, upright, supine, lateral, and obliques, to coat all mucosal surfaces and demonstrate different parts of the stomach. Structures examined: esophagus, stomach, and duodenum. Standard overhead films, PA, lateral, and both obliques. With air contrast, double contrast UGI. Gas tablets are given in addition to thin barium. The gas distends the stomach while the barium coats the mucosa, producing sharper mucosal detail. Views and their purposes. The RAO, right anterior oblique, is the most important single upper GI view. It demonstrates the gastric antrum and duodenal bulb in profile, projecting them away from the spine. LPO demonstrates the fundus and body of the stomach. PA, stomach body en face. Upright demonstrates the air-barium interface and hiatal hernia. Small bowel series. A continuation of the upper GI or a standalone procedure. The patient drinks additional barium and serial overhead films are taken at set intervals. Typically 15 minutes, 30 minutes, 1 hour, 2 hours, until contrast reaches the terminal ileum. Spot compression views of suspicious areas are added as needed. Normal small bowel, valvuli conniventes, circular folds, with a maximum diameter of 3 centimeters. Transit time varies, typically 2 to 6 hours. Enteroclysis. Contrast delivered via a nasoduodenal tube placed to the duodenojejunal junction. Faster and provides more controlled mucosal detail than the oral method. Contrast enema. Patient prep. Full bowel cleansing prep the night before. Essential for mucosal visibility. Enema tip inserted and secured. Barium instilled by gravity or pump. Single contrast. Filling and mucosal pattern. Double contrast. Air contrast barium enema. Thin barium plus air. Patient turned through multiple positions to coat all walls. Films, AP, lateral rectum, both obliques, and post-evacuation. The double contrast technique provides superior detection of polyps and early carcinoma compared to single contrast. Never use barium in a suspected perforation. Never use barium if active toxic megacolon is suspected. Esophagram. The patient drinks barium during fluoroscopy. Views: upright PA and lateral, and the RAO. The RAO profile view is the best single view for the esophagus. Full column technique demonstrates strictures and extrinsic compression. Mucosal relief. Thin barium coating shows folds, varices, and webs. The Valsalva maneuver. Patient bears down, can demonstrate hiatal hernia. The Trendelenburg position plus abdominal compression, used to demonstrate reflux. Modified barium swallow. Not a purely anatomic study, a functional swallowing evaluation. The patient swallows various consistency levels: thin liquid, nectar thick, pudding thick, and solid. A speech pathologist is present, evaluating for aspiration, laryngeal penetration, and residue. Video fluoroscopy. The entire swallow is recorded for frame-by-frame analysis. The lateral view is the primary view. It shows the timing and bolus movement through the pharynx and upper esophagus. Surgical cholangiography. Imaging of the bile ducts during or after surgery. Intraoperative cholangiogram. During cholecystectomy, contrast injected through the cystic duct catheter to detect common bile duct stones before the duct is divided. T-tube cholangiogram. Post-operatively, contrast injected through the T-tube drain to confirm duct clearance. ERCP. Endoscopic retrograde cholangiopancreatography. Endoscopy combined with fluoroscopy. Water-soluble contrast only. Barium is never used in the bile ducts. Intussusception reduction. A pediatric emergency. Bowel telescopes into adjacent bowel. Enema or contrast enema used for hydrostatic or pneumatic reduction under fluoroscopy. Surgical backup required during the procedure. Success confirmed by reflux of contrast or air into the terminal ileum. The table on this slide summarizes prep and technique for each procedure. Upper GI, 8-hour NPO, KVP 100 to 125 for fluoroscopy. Spot films, lower KVP for mucosal detail. Double contrast, gas tablets plus thin barium. Small bowel, 8-hour NPO followed by upper GI barium as the oral load. Serial films every 15 to 30 minutes. Normal transit to cecum, 2 to 6 hours. Air contrast barium enema, full bowel prep the night before. Double contrast gives superior mucosal detail. Never barium if perforation suspected or toxic megacolon present. Post-evacuation film shows mucosal pattern when barium is drained. Esophagram, 4-hour NPO. RAO best profile view. Valsalva and Trendelenburg for reflux and hiatal hernia. Cholangiography, water-soluble iodinated contrast, always. Never barium in bile ducts. Inject gently to avoid bile duct pressure injury. For pathologies, the ARRT test from this lesson. Hiatal hernia, stomach hernia des through the esophageal hiatus. Seen best upright on the esophagram with Valsalva. Type 1, sliding gastroesophageal junction above the diaphragm. Type 2, paraesophageal. The fundus herniates while the junction remains below. Peptic ulcer disease. Gastric ulcer, a niche, a crater, projecting beyond the stomach lumen. Hampton's line, a thin radiolucent line across the ulcer neck indicates benign disease. Duodenal ulcer, bulb deformity from scarring, cloverleaf pattern. Colon carcinoma. Apple core lesion. The classic barium enema finding. Irregular narrowing with mucosal destruction. Annular constricting mass with an abrupt shelf. Double contrast enema is superior for detecting early lesions. Diverticulosis. Rounded out pouchings of the colonic wall. Most common in the sigmoid. Flask-shaped protrusions on barium enema. Diverticulitis, infected diverticulum, is a contraindication to barium enema in the acute phase. 3 digestive system contrast questions. The answer is C, water-soluble iodinated contrast. Barium sulfate is absolutely contraindicated when perforation is suspected. Barium leaking into the peritoneum causes a severe, often fatal, chemical peritonitis. Water-soluble iodinated contrast is safe because if it extravasates into the peritoneum, It is rapidly absorbed without causing catastrophic inflammation. This is one of the highest priority contrast decisions on the ARRT. The answer is C, right anterior oblique, RAO. The RAO position places the gastric antrum and duodenal bulb in profile, projecting them to the right away from the spine. The LPO demonstrates the fundus and body. The RAO is the workhorse view of the upper GI series for antrum and duodenal evaluation. The answer is B, to coat all walls of the colon with thin barium while air distends the lumen. In double contrast barium enema, the thin barium pool coats the mucosal surface and the air distends the lumen. By rotating the patient through multiple positions, the barium pool redistributes to coat every wall segment, while the air follows to the non-dependent surface. This ensures complete mucosal coverage for polyp and early lesion detection. Lesson 12 complete. Barium versus water-soluble contrast with a perforation contraindication, upper GI procedure, and views, including the RAO for antrum and duodenum, small bowel series, double contrast barium enema, esophagram and modified barium swallow, surgical cholangiography types, intussusception reduction, and GI pathology including hiatal hernia, peptic ulcer, apple core carcinoma, and diverticulosis.